to those who invited me to present tonight. So my name's Jodie Thompson and I'm a clinical nurse consultant and nurse continence specialist. We're going to go through a whole heap of information today in relation to, continence, comorbidities, as well as Ehlers-Danlos syndrome. To begin today, I'd like to acknowledge our traditional custodians of the land of which we're beaming to you from today, which for myself is the Darug land, and we'd like to extend our invitation for and welcome to anyone who may be Aboriginal of Torres Strait Island today. So let's get stuck into it. So I have to explain the picture to begin with. So anyone who happens to know me knows me that I am a Ted Lasso tragic, which is a show that's on Apple television, and the main star of the show is Hannah Waddingham, and she's actually the poster child for joint hypermobility, and so I thought it was quite relevant and stuff to include her in the presentation today and all the chaos that she brings. So to make it a little bit fun and light, being that it's 7 o'clock of a Thursday night, we're all probably fairly exhausted. So the things that we're going to go through today are a little bit of background and kind of where my interest is in this area and things. And we're going to cover some of the comorbidities that actually lead to that potential thinking that perhaps Ehlers-Danlos is an issue for people. So we're going to look at a brief look at sort of neurodiversity, joint hypermobility, postural orthostatic tachycardia syndrome, or otherwise known as POTS, mast cell activation syndrome, and then we're going to talk a little bit about Ehlers-Danlos syndrome and the role of the continence nurse specialist, and we might also explore a couple of case studies and things. So by way of background, I used to work at the Children's Hospital at Westmead. I was there for about 26 years, primarily working in the area of kids rehab. So I was looking after children with acquired spinal cord injuries and acquired brain injuries. However, when I set up my business, Kids Collaborative, in 2019, I was still working part-time at the hospital, but the children, when I started doing continence assessments, the children that were coming to see me, in fact, were those children who are neurodiverse and had rare conditions. And so I was suddenly sort of thrust into this world of something that I'd come across, but it wasn't really, I wouldn't say it was my specialty by any means. So lots of education and learning about sort of some of their comorbidities and things as well has been really a bit of a journey, to be honest. And now I sort of feel like the neurodiversity part of it's been what I sort of specialize in. Having said that, and please don't think that I am an expert in Ehlers-Danlos, because I'm not, but I'm going to share the journey of the information that I've learnt along the way that maybe will make you question about the clientele that you see, if there's anything that is interplaying with that, or is there the possibility of Ehlers-Danlos by way of their continence presentation and things. So now I'm primarily doing independent nursing assessments and continence assessments, and I'm working a crazy 6 days a week. So for myself now, it's been an interesting time out in private land. So I'm going to take you on a bit of this journey of discovery. So as I said, we're going to talk about that neurodiversity and how prevalent joint hypermobility is in this population of pediatric children that I see. But there's also these other associated conditions like POTS and MCAS, and how that sort of then leads into Ehlers-Danlos. So we're going to unpack some of that today. So neurodiversity, why is it important? And our numbers of neurodiverse people are increasing and things. And as of sort of mid 2024, they are looking at about 1 in 40 individuals maybe on the autism spectrum. And that's about 675,000 people in Australia, which is probably an underestimation, to be honest. It is 4 times more common in boys than in girls. And females tend to have a sort of higher mental health issues, and they actually mask a lot of their difficulties better because they're very good at being able to mimic others. And so a lot of the times they do fly under the radar, and that often leads to a later diagnosis of some of their difficulties. And then we also are seeing an increased presentation of ADHD. So that can be either inattentive, hyperactive, or a combination of both of those. It's the most common neurodevelopmental disorder in children and adults. And they estimate it to be like 6 to 10% of children and adults in Australia actually have ADHD and things, and the incidence is actually higher in boys than in girls, and girls tend to be diagnosed later. And I can give you an example of that because I've got a 15-year-old daughter who's actually just been diagnosed with combined ADHD. And inattentive ADHD is the most prevalent in things. So we're seeing increased amounts of neurodiversity. It's being recognized more so, and especially for, females who are like 40 in their 50s, and they're realizing that some of the struggles that they've had over the years, in fact, may be ADHD related. So very interesting sort of space to watch as this is unfolding, as there's more knowledge and understanding about how it presents in different ways to males and females. So, of course, I talk a little bit from the pediatric angle specifically around this because that's who I see, but it also is applicable to adults, or may actually explain some of the journey that they've gone on before they got to adulthood and why they've now got chronic, issues with their continence. So why do neurodiverse children have toileting challenges? Well, there's a whole variety of reasons. Number one, they've got a developmental delay generally, affecting their cognitive, motor, and skill development. They often have reduced muscle tone, especially core strength, and many have joint hypermobility, which we're going to unpack some of the issues related to that. Many might actually have some other underlying genetic conditions, or potentially other bowel or bladder conditions which aren't well recognized and often missed. They can have lots of challenges with their communication and cognition and their ability to be able to follow instructions, which can hinder their progress in being able to, apply some of those, to their toileting and things. They have often reduced interoception and not kind of really reading those signals that they're in their body. They have, issues with body awareness and proprioception of knowing where their body is in space. And that goes for wiping, because wiping often is a real challenge for the children. And especially when they're hyper focusing on, preferred activities, they just lose all interoception. They have no idea that they're kind of what their toileting needs are. They can have lots of sensory processing challenges, lots of behavioral and emotional regulation challenges. Some children are very routine driven, and so trying to change those routines can be difficult. And they also have challenges of transitioning between, especially going from a preferred activity to like a non-preferred activity. That can be really difficult for them. So say, for example, they get the feeling they need to go to the toilet, but the transition to actually go use the toilet can be particularly challenging. They can have quite restrictive diets. We've all heard about that white or beige diet. And they either have reduced or potentially excessive fluid intake and things. So I've got some children that will barely, have 500 mils of fluid a day, or they may have 4 litres of fluid a day, and we're wondering why they're having some issues with urinary incontinence. They also often have a reluctance to use the toilet due to lots of sensory challenges and things. So that environment stuff can be really challenging. So, in a nutshell, and as I said, this could last a whole presentation, just this topic itself. But in a nutshell, the common toileting issues that I see in our neurodiverse kids are urinary incontinence secondary to constipation. That's one of the hugest things I think, mostly for this population. Looking at withholding or delayed voiding, which then results in them, experiencing urgency and urge incontinence, especially if they're sitting on like an iPad and they get they're so hyper focused on that they don't realize they need to go to the toilet. They don't get those early messages, and then suddenly they're having to run to the toilet, and they may have an accident on the way through. They can get like some children I see, not there's very few of them really that have any true overactive bladder, but it's something always to keep in the back of my mind about sort of screening for that. Stress incontinence, if the children have got joint hypermobility, stress incontinence can be an issue for them. And a lot of them have underlying sleep disorders, which affects their primary nocturnal enuresis tends to last longer into the ages of 7, 8, 9 and beyond, and things. In terms of their bowels, as I said, there's a lot of underlying conditions. Commonly, celiac disease or lactose intolerance is common, and commonly missed. Constipation is one of the worst things for these kids and stuff, and often it's due to slowed gut motility, or restricted diet and fluid intake, and that's kind of a bad combination. They associate pooing with pain, and therefore that leads to increased withholding, and so therefore constipation then becomes worse, and that's very common. And also for the children, often the children who present who are non-verbal may have autism spectrum disorder sort of level 3. They often can be sensory seeking and do lots of sensory seeking behaviors, and that includes deep diving and not only into their nappy if they've felt that they've passed a stool, and they like to sort of get the feeling of that. They like the sensory feeling of that, and then they like to share it around. Or I've had other children that are just have such a strong drive to like get to the toilet water, and they'll go deep diving and stuff in the toilet water. So they can be some of the really big challenging issues and stuff. So I start with neurodiversity because that leads us on to joint hypermobility. So if you've ever had friends that can do party tricks with, being double jointed and can bend in ways that look like it's quite abnormal, that's joint hypermobility at its best. So what is it? So it's actually a connective tissue disorder. So it involves sort of hypermobility of our joints, and often a lot of joint instability in relation to that. And so our muscles and things like that need to help support our joints so that we don't start dislocating them and things. So we've got connective tissue all the way throughout our body. It basically supports, connects, and separates different tissues and organs. Our ligaments are the thing that holds our skeleton together so we don't just all fall apart. And as a result of, those ligaments and things being a bit more stretchy, it's to do with the collagen formation of our connective tissue, which is a little bit different, and it allows for increased stretch of ligaments. So it means that we rely on our muscles to be able to hold our body together. And often as a result of that, you can actually get quite stiff muscles, but you actually have still quite lax ligaments. This can lead to things like subluxations, dislocations, sprains and things, especially like ankles and things. Ankle sprains are very common. As well as that, you actually have the fascia, which is another type of connective tissue that actually holds our organs apart, so that when we are lying down and we go upright, then everything that sits below our diaphragm doesn't fall to our pelvic floor. And that allows our organs to work optimally. However, when the fascia is also stretchy, it means that that organs can then kind of nest a little bit harder on others. So things like, and our bowel, of course, being one of the most predominant organs, gets sort of a bit squished by other organs, and especially our bladder and where the bladder sits and things. So that's why we often see a lot of stress incontinence, and that the result of pressure and stuff on the bowel is that you can get slowed gut motility, kind of putting you more at risk at constipation. And that's a really common thing in our neurodiverse kids. And so we also have obviously connective tissue in our pelvic floor and stuff like that. So in relation to pelvic floor control and things, that can be affected if those ligaments and fascia are also stretchy. And we also, as I said, we have an increase, it's known to be, have increased incidence of stress incontinence and constipation. Alrighty, so joint hypermobility, you might have heard it referred to in lots of different ways. Some people would call it benign joint hypermobility, joint hypermobility syndrome. They now referring it more to hypermobility spectrum disorders, and these are sort of disorders that have joint hypermobility, but other disorders such as Ehlers-Danlos, Marfan's, Downs have been ruled out. So if you've got joint hypermobility related to those other syndromes, that kind of gets under the banner of those syndromes, but everything else gets classified as hypermobility spectrum disorders. It's known to be associated with increased pain and fatigue, muscle pain and fatigue, and things you often see like quite poor endurance and things like that in people who have significant joint hypermobility. You can actually there's joint hypermobility is actually quite common in the general population, but for a lot of people, it doesn't have a significant impact on them. It's those people that actually are very hypermobile. They're the ones that actually really feel a lot of these different side effects and things. You can also have underlying cardiac conditions and things as well, can affect your, vascular return of fluid and stuff like that, of facilitating fluid back to the heart. You can have issues with your vision and things. So again, I'll give you the example. Both my children are actually hypermobile, and my son, he used to have difficulties at school between focusing on the smart board. Then there was a delay in him being able to focus on his work and things in front of him and things. So there can be some visual issues, often associated with reduced core strength, and sometimes that comes as a general sort of overview of poor muscle tone. All over the body. You can get slow gut motility leading to constipation, stress incontinence. You can also have other associated things of dizziness and headaches and dysautonomia and anxiety. And also, just as a side thing, is that if you do have significant joint hypermobility and things, often local anesthetics don't work very well. So if you're, having a local anesthetic and you're finding it's not very well, it's because that, when they inject the local anesthetic, it doesn't stay in the area. It actually, because of the connective tissue formation, in fact, it actually gets dispersed very quickly. And so you're finding that people who, if you need to have any local stuff and it doesn't work for you, well, that's the reason if you have joint hypermobility. So how do we measure it? So this is what they call a Baton score. It's not a definitive, sort of answer to say if you've got joint hypermobility or not, because it only sort of assesses in certain planes, and it's a very basic assessment. But it's something that I screen all the kids that come and see me. I screen for this. So they look particularly at, whether you can get your little fingers beyond perpendicular and things. I look to see if you can get the inside of your thumb along your forearm there. They look to see if when you put your arms out, do you look like you've got more than 10 degrees of hyperextension? And the same with on your knees. Do you look like you kind of sit back into your knees? And then if you stand up and bend over, does it look like you got a bit of hypermobility in your back if you can get your hands flat on the ground? Now, for each positive that you get of that gives you 1 point. It's a score out of 9. If you score more than like 6 and above, that's considered to be of significant hypermobility. So the importance of recognizing this is that hypermobility in itself can be significant or insignificant to someone. Like some people aren't too bothered by it, don't get a lot of symptoms with it, and that's fine. But for some people, it can have a massive impact on their life. It can have other associated conditions with it if they do have significant joint hypermobility, which we're going to unpack next. Whether we need to be thinking about whether the person's incontinence related to this condition will actually affect our management options and things for them. Because if we can recognize whether we think that this is actually impacting on them, then maybe we might do things a little bit different as to what our recommendations would be as nurse continence specialists. And looking at, I'll give you the example of, and I'll go through this as one of my case examples of like whether traditional positioning on the toilet actually works. So we've talked about how the fascia, can be a little bit more stretchy. Well, I've got kids, when I sit them on the toilet and we get their knees up higher than their hips and they're leaning forward and all the rest of it, and it doesn't work for them. And that's because their internal anatomy actually doesn't sit in the normal way because their fascia is a little bit more stretchy. And that was something that was really, I'm like, what do you mean you can't go to the toilet? Like, this is something that should just naturally happen because of that. And also thinking about their pelvic floor control and things as well. And just making sure that the right professionals are involved and things in this. And this might be, might need a pelvic floor physio. You might need a urologist or your colorectal surgeons or your gastroenterologists and things. So it can have a significant effect on continence. So, worth doing a little bit of a deep dive on that yourself. If, and some of you may actually be looking at home yourself to see if you've got a bit of joint hypermobility. Alrighty. So the next thing I want to talk about is POTS and things. So postural orthostatic tachycardia. It's something that is not well recognized. They feel that, and it's a type of dysautonomia. So it can be this sort of life-altering and debilitating condition. The recent research is actually thinking that this may actually be an autoimmune type of condition, and that in fact it's associated with also increasing numbers because of long COVID. And females are more likely to be affected and things by this. So, worth noting, and you might go through this yourself and you're like, oh, I'm actually recognizing some of these symptoms. So it's actually quite interesting. So, what it is an abnormal response by the autonomic nervous system. So, characterized by orthostatic intolerance when standing, but most of the symptoms, if you were to lie down, are actually relieved things. So it's associated with a persistent increased heart rate when moving from, say, for example, laying down to being upright, and your body it starts to compensate and things, and it increases your heart rate. So the symptoms of this can include things like palpitations, lightheadedness, fatigue, excessive sweating, presyncope or even fainting, chest pains, shortness of breath, headaches, shakiness, vision issues, and that, can be adjustment to like glare, going from a dark environment to a light environment. You can get blurred or tunnel vision, brain fog, exercise intolerance, poor sleep. I think I tick most of those. We also, but more importantly, from us continence nurses, POTS is associated with things like nausea, diarrhea, constipation, bloating, abdominal pain, vomiting, and often people are written off as saying, oh no, you've just got irritable bowel syndrome, when in fact it's not this at all. It can get worse in excessive heat. After eating some, say, for example, refined carbohydrates and things where there's a lot of blood is pulled into the area to aid digestion, and it can drop your blood pressure. Dehydration can make it worse. The speed of positional change. So if you do things really, if you move very quickly from, say, for example, a laying down to a sitting position, that can actually make it worse. Menstruation can make it worse. Deconditioning, and also alcohol and things can make it more difficult. So since sort of learning about some of this condition and things, and I started following a few people on TikTok talking about their lived experience. And one of the girls on there was talking and explained it really well. So I thought I'd kind of, reflect on that and what she was told by her cardiologist about what this was about. So obviously our autonomic nervous system, controls sweating, breathing, shivering, heart rate, temperature, blood pressure, blood circulation and digestion. So when a well person stands up, so if you or I to stand up, we briefly sort of pull fluid in our legs, but because our body recognizes that and thinking, oh, hang on a minute, I've got to compensate for that. And so we have vasoconstriction kicks in, and that helps with pushing the blood basically back to your brain and your heart again and things. However, in POTS, this autonomic function doesn't work. So it means that blood continues to pool in the lower half of your body, and therefore it's not getting back to your brain, which is the reason why you start to experience some of these symptoms. And so it's actually the symptoms are your body actually trying to compensate for that. So, what happens is your body goes, hang on a minute, I need to get that fluid from down low up high because otherwise you're going to pass out. And so it does this massive adrenaline dump. And so to help increase your heart rate, to actually try and compensate. So that is why you get that increase, fast heart beating and things. But it sets you into this state of fight or flight. So you can imagine if you are neurodiverse and you've got some joint hypermobility and you've got POTS, which also increases anxiety, this is kind of can be a really challenging condition and things. So you can get that brings on feelings of anxiety, nausea, vomiting, dizziness, lightheadedness, heavy limbs, muscle weakness and fatigue, balance issues, and loss of vision. I'll give you the example. My son, when he was in about year 8 or year 9 at school, he went through this period of sitting down for a double period in, like, say, for example, maths, and where he's not moving around at all. All the blood used to pool to his feet. He would go to get up at the end of the lesson and forget that he needed to be moving his legs. He would stand up and then he would pass out. So he did that 2 or 3 times. And being the nurse that I am, was very much like, school called me and said he's fainted. I'm like, that's fine, just shove his feet in the air. He'll be fine. It's probably just POTS and, he'll be good to go. So, like a typical nurse mother, very much downplayed that, and things. So what does it mean for continence? And you can imagine if you're experiencing these symptoms and you get this big adrenaline dump, what does that do to your continence, and what does that do to your bowel? So, if you're nervous, the nervous poo, so to speak, you can imagine yourself like that can play havoc and induce things like diarrhea. It can also then lead to potentially constipation, bloating, abdominal pain, vomiting. Often people have said, I've written off and said, like, oh, it's just IBS, really. And it's like, well, actually, no, it's actually a response to the symptoms of POTS. And, comes with high levels of anxiety, and also can come with reduced sexual function and stuff as well. So reduced arousal, desire, satisfaction, erectile dysfunction. So it can be really significant. And if you don't sort of understand it or have never seen this before, I encourage you to go do a deep dive, because I think that this is something that's, very, very relevant for a lot of the like pediatric and adult clients that we see. So, how do we test for POTS? Number one, we really want a detailed medical history. They go through like the diagnostic criteria as such for that. They actually look to see if like POTS symptoms experience when they're upright, but basically it's relieved when laying down. So, if that persists for a period of over 3 months and things like that, that they're complaining of the symptoms, then they look further into it for POTS. So, they look to see if you've got a sustained increase in heart rate of 30 beats a minute within the first 10 minutes of standing. And for the 12 to 19-year-olds, they make that a 40 beats per minute. And usually there's no actual drop in blood pressure on standing and things. The investigations and things that they look at, they'll look at ECG, echocardiogram. They actually look for sodium levels and stuff in a 24-hour urine, and they'll also take bloods. Now, often when you go to a cardiologist, they go, there's nothing wrong with your heart. And it's right. Often there may be nothing wrong with your heart. It's actually all the other symptoms around that actually that cause the increased heart rate and stuff. There's a couple of different standing tests and things that they can do. One is called a active standing test. They look at heart rate and blood pressure measured after laying down and then on standing at different intervals for about 10 minutes. And usually that needs to be done under very controlled conditions, because often the person will actually pass out in the end, and things. And again, with the heads up for the tilt table test and things like that, they do a similar kind of thing where they put you on a tilt table and they actually then try test you to see what happens. And often, again, you can potentially pass out. So it needs to be done under very controlled conditions and things. So how do we manage it? Hydration is one of the biggest things, making sure that you're having 2 to 3 liters of fluid a day. They recommend an additional 6 to 10 grams of salt each day. The diet, it can actually be worse if you have quite high carbohydrate meals and things, and that's where, because they get a lot of that redirection of blood to the gut, which then drops your blood pressure and things. Compression garments can help, and things like lower limb compression garments. Exercise and movement prior to standing, avoiding extreme temperatures, which then dilate, of course, your vessels even further as your body tries to cool itself down and makes it more difficult to get blood back to your brain. Also learning about controlled breathing, because often when when you've got a lot of fluid that you can't get back, like a lot of blood that can't circulate back to your brain starts to go into like that fight or flight and panic. And that makes you increase your breath rate and things. And actually what we need to do is actually slow that down. So actually learning about controlled breathing and things like that's important. And they've also a variety of different medications and things that can actually assist with that as well. So POTS again is strongly associated with joint hypermobility, as is muscle activation syndrome and things. And so that's what we're going to chat about now. So, this is one that I struggled to get my head around, to be honest. Like it's quite complex. So basically, mast cells are all the way throughout our body. It's a type of blood cell that are involved in immune responses, particularly in allergic reactions and inflammation, but also involved in like wound healing, tissue repair, and also heavily influenced like pain, sleep, pain, sensory perception. They're found throughout the body. They reside in connective tissue. So remember what we're thinking about when we go back to joint hypermobility. All these things are connected, and it surrounds blood vessels, nerves, our lymph, as well as our eyes, nose, airways, lungs, GI tract, um, the urogenital tract, and the skin. So when these mast cells are activated, they degranulate and they release thousands of chemical mediators that trigger lots of different inflammation responses in the body, and it can lead to multi-system inflammation and kind of allergic reactions and things throughout the body. So it's a chronic multi-system condition of abnormal mast cell activation, widespread inflammatory and allergic symptoms and things. The often associated with is like the irritable bowel or the fibromyalgia. In fact, maybe mast cell activation. So, how prevalent is this? Well, it's likely to be prevalent in about 17 to 20% of the general population. And we know that 81% of Ehlers-Danlos patients have it. It is symptomatic, the symptomatic hypermobile patients often have mast cell activation and POTS or dysautonomia. It often presents in childhood. It is not well recognized. It is multi-system and inflammatory in nature, and can be very inconsistent with its presentation. They can have different triggers to cause these different inflammation responses at different times, and often they can be mistaken, as psychiatric or somatic issues. And the triggers and things for these different mast cell activation may include like sensory, environmental allergens, diets, drugs, dysbiosis, micronutrient deficiencies, or hormone changes and things. So they talk about the histamine bucket and things. Now, the histamine bucket, they describe a whole heap of different things, of different allergens and things. And at sometimes you may react to different ones. Other times you think, oh, I've been exposed to that again, but I didn't react to it. It's all about how your body interprets a whole heap of different sort of allergens at the one time. And often it's the one drop that kind of then overflows the bucket. And that's when you start to get that mast cell activation. So it's not consistent. So some of the symptoms and things that we see are things like fatigue, insomnia, temperature, intolerance, cognitive impairment, irritability, sensory sensitivity, dysregulated glucose control, frequent infections due to the immune response. You often see people have like, watery or itchy eyes, runny or stuffy nose, tachycardia, vessel fragility, breathlessness, reflux, dysphagia. Like there's like over 200 symptoms. And I just pulled out, like a handful of the common ones that I was seeing. And again, you look at all the ones that relate back to continence and things, but it can cause things like voiding dysfunction, urinary retention. And so these are really important things to get a really good history and actually screen a lot of our clients for any of these type of overall general allergic reactions and things. They can come up with weird and wonderful rashes. There is a questionnaire which I've put the link in at the end that gives you a little bit of a screening tool that you could then take to your GP or your gastroenterologist or your specialist and say, hey, do you think that this may be something that I'm experiencing and whether we need to be actively treating myself for mast cell activation versus it just being other, possible conditions or written off to be, a lot of medical health professionals gaslight like patients. And so it's really important that we go armed with as much information as we can so that people just don't recognize it. It's really sad to see some of the stories that come out of people just going, I've had this for years and no one would believe me. Hence why my interest and passion in this area. That leads us on to Ehlers-Danlos. Now, Ehlers-Danlos is often associated with POTS and mast cell activation, and neurodiversity is also very common in this population. So hence this journey to kind of where we come to with Ehlers-Danlos. So it is a group of about 13 heritable connective tissue disorders. It has its own set of features and things for all those and diagnostic criteria for those different, the group of 13 of them. Some of the features, such as joint hypermobility, skin hyperextensibility, and tissue fragility is common across all of them. And they look to see, how stretching and stuff your skin is, and they look to see if your skin can stretch 1.5 to 2 centimeters, and things. If you were to pull it out, they're kind of, and you can watch people like pull their skin right out, and things, and on their hands and things as well. You'll notice that they're a lot more flexible with their, and very elastic skin. They can have really easy bruising and things, poor wound healing. You often get really atrophic kind of scarring and things like that. And you can have lots of issues with vessels and things throughout your body, and things with one of the different types, which I'll explain. The hypermobile Ehlers-Danlos syndrome is the most common, and accounts for about 90% of all Ehlers-Danlos patients. The true prevalence, however, is very likely to be underestimated. So these, I won't go through them all. I just want to highlight the first three. So this is the first one where it's about 1 in 3,100 to 5,000 people. So it's actually fairly common, and things as rare conditions go. And it is characterized by generalized joint hypermobility, lots of joint instability, and also chronic pain. And you have then more of a classic EDS where you get more of that kind of skin fragility, lots of scarring, stretchy skin, quite velvety. They often have really beautiful velvety, kind of skin that you kill for, really. But the more kind of dangerous one, I guess, is vascular EDS. Now, this is only 1 in 100 to 200,000 people where you get arterial fragility. So that can often see you with aneurysms, dissections, or ruptures of those, organ fragility, extensive bruising, pneumothorax. This is the one that if you're showing signs of lots of that vascular stuff, they're the ones that are going to send you off for genetic testing. And unfortunately, with just generalized hypermobile EDS, there's actually no genetic test currently for that. They're looking into that. I think they're getting close, but they're actually looking more at their presentation. Classic EDS, they can actually test for, as well as all the rest of the Ehlers-Danloses, but the most common one, they actually go by just symptomatology. But vascular EDS, if there's questions around that, they will get you, you will be urgently seen, and you are prioritized for genetic testing for that. There's other ones such as periodontal EDS and kyphoscoliotic, and lots of different ones related to sort of different craniofacial and scoliosis, and ones of specifically related to the cornea of the eye. They've got lots of multiple contractures, for one of the musculocontractural EDS. There's so many of them, but very classic in the way that they present and things, and there's very interesting kind of when you look at how they present, they can all look just slightly different. Alrighty, so there is a generalized sort of diagnostic criteria and things. Again, I've put this in the link and stuff that you can actually go through and see how many, things that you tick on this. And it gives you some, evidence to actually be able to take to medical health professionals to go, hey, do you think I've got EDS? And the continence nurses can be the ones that kind of instigate this to assess with that, help with that screening kind of process. And I think it's really important that we consider that because we know how much it can have an impact on continence. So this is the trifecta. So this is POTS, mast cell activation, and hypermobile Ehlers-Danlos, or even hypermobility spectrum disorders. You often get what they call the trifecta, which is the intersect. It is all these conditions are very, very interlinked, and the combination of those is the weakness, fatigue, abdominal pain, nausea, vomiting, diarrhea, bloating, all those things that we've talked about. can be as a result of these conditions, and it's trying to flesh those out with the history that you take and things about whether this is going to be an issue for that person and does it affect the way in which we then prescribe or suggest, management strategies and things, and whether other health professionals are needing to be involved. So why is early identification EDS important? It's not well recognized by health professionals, and it isn't always experienced in isolation. You always often, if you've got EDS, you often have POTS and mast cell activation. A lot of health professionals don't understand that intersect and things. And it can have a massive impact on people. A lot of people with EDS and feel like they've been medically gaslit by a lot of health professionals. There's a lot of medical trauma associated with that for many, many years, that they've been not believed, their symptoms are not believed, and they're written off as being psychosomatic or functional. They, on average, and it surprised me at the latest EDS conference that was back in Brisbane in February, they were saying that it takes on average 16 years to be diagnosed with EDS, and that's like crazy. Like, to not be believed for that long is very sad. And only vascular EDS, as I said, is the one that's currently been, mostly genetically tested for because of the catastrophic consequences if that's left underdiagnosed. And it can have significant impacts on a person's quality of life. So in terms of what does it mean for us for continence assessments? I screen all my clients now who especially have joint hypermobility, have neurodiversity. I screen them for joint hypermobility. And if they've got joint hypermobility, I look to see if there's any other signs there of anything else. So I look to see, do they have, what do they look like on a Baton score? Have they had any history of subluxations, dislocations, sprained ankles? What does their skin elasticity look like? Do they bruise easy? Are there other signs of POTS? Now, in pediatrics, that can actually be really hard, especially for children that can't describe their symptoms and things. Are there signs of mast cell activation? Do they have any other, asthma, eczema, urticaria, rashes, unexplained rashes, itchy or watery eyes, nasal stuffiness? Were they a really refluxy baby? That often kind of signs that, they do have a tendency of that in their body. And have they had any hyperextension or flexion injuries of their neck and spine? Because for some children, that can actually cause some neurogenic kind of picture for when we're thinking about continence. Have they been tested for celiac disease or lactose intolerance? And knowing this information then forms the lens of what we're looking for in the rest of the assessment and things. So what's our role? As I said, nursing's often in a lot of these conferences and stuff. Nursing wasn't a prevalent part of these potential health professionals that can help diagnose this. So at the Ehlers-Danlos conference, I was always on the chat function because I joined online, and I'm going, hey, what about the role of the nurse in this? Because I think that we have a unique opportunity to be screening people through the lens of continence, but in fact, putting these questions around whether this is an issue for people or not with these various comorbidities. Our job is to screen for potential symptoms and things, and then refer them to the appropriate professionals for diagnoses and things. And in the Ehlers-Danlos Society website, which I would encourage you to go have a look at, they've got some great resources there. They have a list of health professionals who have an interest in this area and things. And there's very few and far of them between. So if you're looking for people maybe with assistance in this area, then have a little look at their directory. Screening informs the likely reasons for incontinence in all ages, and our approach to treatment and a multidisciplinary approach is very important. I know we're pretty close to time. I'm just going to quickly just mention briefly these couple of case studies just to demonstrate what I'm talking about. So there's an 11-year-old girl that I saw several years ago now who was known to have hypermobile Ehlers-Danlos. She had two older siblings that was also being officially diagnosed with it. She had significant amount of fatigue, pain, really poor core strength, reduced endurance, and highly anxious. She likely had POTS. Looking back now of what I know now, I would think that she also has POTS and mast cell activation as a couple of other comorbidities. She was only attending school 1 hour a day, a few days a week, and she was sleeping the rest of the time. She was that exhausted. She wasn't able to participate in any other activities outside of school, and that screening uncovered. She got a new Apple Watch, and she had only just got that in the week before. And her mum mentioned to me in passing that, in fact, when she looked at her, what her saturations were and her sleep was overnight, she was actually desaturating to her low 80s overnight. So she had an underlying sleep disorder that was likely causing a lot of that fatigue and things as well. And we got her straight in to see a sleep specialist. Hence why it's very important to do lots of screening. She had a history of chronic constipation. She ended up having a form of a MACE and stuff. So for antegrade washouts and things a couple of years beforehand, before I had seen them. So she was putting in about 300 mils or so of fluid through that MACE to help with, evacuation of her bowels. But the only way that she could open her bowels was when she sat on the toilet, nothing happened. Nothing came out. And I'm like, where's it gone to? And so she said, the only way I can do this is to actually put a pull up on and get on my hands and knees. And that's the only way that it could come out. And that's at the point of where I learned about the differences in the fascia and how that can affect anatomy. And of course, I then got on to the colorectal surgeon and I'm like, please explain in English, explain it to me like a 5-year-old. Why is this happening? And he said, actually, we probably need to do like a functional MRI. And after that time, after I'd flagged that with him, the family went back and saw him. And I do believe down the track, she actually ended up having formation of a colostomy because functionally for an 11-year-old who couldn't sit on the toilet to actually, get things out, it wasn't, appropriate for her just to be able to have to be able to do it in a pull-up. So that was just one of the cases that really made me wake up going, this is a really big issue and we need to be like the strongest advocates, in this space and have a really good understanding. Alrighty, I think I'm over time, so I won't go into my second one. I just wanted to flag further training and stuff. The Ehlers-Danlos Society holds a Echo series and stuff, which is brilliant. It is one of the best series that I've ever done. And they've got another one coming up in September, which is talking about some of the musculoskeletal side of things. They talked last time about MCAS and POTS and dysautonomia stuff. This time, the next sort of series, which is a series I think of 6 nights, is coming up in September. And information about that's on the Ehlers-Danlos website. They also have a scientific symposium which is being held in Canada, but I believe you can join online and even look at some of the presentations and stuff afterwards. Here's a list of my references. You're welcome. I just want to flag Megan Thomas is one of got some information of hers that I used tonight from the mast cell activation. She's a specialist GP based in North Wollongong in New South Wales, and she's got some really interesting resources on her website. Alrighty. Be curious, not judgmental. Again, another Ted Lasso reference, which fits kind of nicely with the work that we do. I'll open the floor, I guess, for questions now. So sorry, there is a whole lot of information there that I've thrown at you tonight. It's really important that we have a look at this. I hope it's kind of put some questions around why it's important that we need to be doing screening for these conditions, because I think it goes really under recognized. And if you're having difficulties with certain clientele, with getting them continent and things, that is something that maybe you need to be asking some more questions around these, and if that will then find some different ways to be able to assist them. Alrighty.
Thank you so much, Jodie. That was amazing. I learnt so much. And there's still a lot I will need to look up, and because it's a syndrome that I haven't really had dealings with, but especially with your case study, I thought to myself, oh yes, I think I've actually seen someone with the syndrome, but not actually recognized it myself. Now, if anyone's got any questions, just remember to unmute yourself and you can ask your question now.
Do you want me to end my slideshow? Is that easier?
Yeah, that would be good.
I've got
I'll be able to see everyone's face on the screen if they've got their video on, and I can see if anyone looks like they're wanting to ask any questions. So I might ask a question. So can a child have the mast cell, I'll just say it, mast cell
Activation syndrome?
activation
Yeah.
syndrome? Yep. Um, and it only, the only of, well, do they get any blood, like on blood testing, are there any abnormal, like say, are their white cells elevated?
They can be, yeah, they can have inflammatory markers and things like that. The problem with trying to test for some of that is, in fact, there's this really stringent testing where you need to have, be able to take bloods within, I forget what it is, it's like within 4 hours of, a mast cell kind of activation, and then it's got to be the bloods are got to be processed within like 40 minutes or something. It's like ridiculous protocol that a lot of people wouldn't be able to do. And so often they go by symptomatology versus but there is ways to clinically test for those inflammatory markers, but it's really hard to actually get it in the window that they need it, and things. So, but yes, they can. And absolutely, yes, they have different inflammatory markers. Don't ask me what they are because I'm not the expert, but I know that that's what they do, but they tend to go by how they're presenting and stuff. In terms of their symptomatology, and looking at their medical history and because they can present in different ways as well, depending on what is, what sort of set them off, you know what I mean, type of thing, and things. What was that final straw, or the final drop in the bucket, and things that sends it off. Yeah.
So do you find that they need to have all of those symptoms that you listed, or could they just have reflux?
They can have just literally, they can just have often they'll come in a few different symptoms, but it's not to say that it might just have one,
Right.
absolutely, and things. So it can be a combination of different, you might get like these weird rashes that come up and down, and then suddenly you're getting a bit of reflux, and so there can be, it can be a mixture. As I
Right.
said, and that's why it's so hard to diagnose, because everyone looks at the history and go, well, you presented that you think that that's the thing that caused it last time, but this time that wasn't the thing that you were exposed to again. So
Right.
so it can be really hard, and a lot of people, I mean, they often, Dr. Megan Thomas was actually saying, she says, it's a bit of a theory, and she said she's got the theory of that, in fact, irritable bowel syndrome, in fact, might be mast cell activation syndrome. She
Right.
said, yet to get the medicos on board, she says, but as someone who's got EDS and those symptoms and stuff herself, and she's a specialist GP and she's learned to manage it really well, and things that she's like, no, I'm pretty sure that, and things like fibromyalgia and things like that, where that gets worse at different times, actually, in fact, there may be some ties to mast cell activation.
Wow. I've
Yeah,
got a 1-year-old great nephew who has had reflux his whole life, and
yeah,
he's now had to have a nasogastric tube put in.
yeah,
Uh, and he is tolerating the nasogastric feeds, but he's also got an unusual high white blood cell count. And
yeah,
so, anyway,
yeah,
I'm just going to get my niece to look
yeah.
at mast cell activation.
Absolutely, yeah, absolutely.
Yeah.
And have a look to see if they've got any other symptomatology, like weird, rashes or nasal stuffiness, itchy eyes, those type of things as well, that show you that's more of a broad inflammatory kind of responses in the body. It's multi-system, we need to, yeah, look out for those. Yeah.
Oh,
Yeah.
fantastic.
Cool.
There's no questions
And
that I can
Jen's
see.
got a hand up. Jen Aiken's
Oh,
got a hand up.
awesome. Go for it, Jen.
Wow. Am I on yet? Oh,
Yeah, you
No.
hi.
are.
Jodie, that was just mind blowing. And there's so many aspects and rabbit holes that I need to go down
It is.
and
And
follow up
that's very
on.
much how
It's
I felt, and I
crazy.
still feel every day. I still feel like that. So,
And you know what? I think that you get an overview of kids, and kids are very honest.
mm,
I see adults, I see
yeah,
them when they're 50 and they're
yep,
saying, I've
yep,
got Ehlers-Danlos. And they've got all that, a lot of mental health issues,
yeah,
very,
yeah,
very, very complex, a lot of trauma history, a lot
very
of
much.
gaslighting. So I think, the spectrum that I look after, which is the older one,
Yeah, yeah,
is probably a little bit more confusing. Whereas that
yeah,
the kids are probably a little bit more honest because they're young and it's
Yeah.
quite clear about what's happening.
But a lot of the time a lot of that anxiety and stuff comes from being medically gaslit, that people aren't believing their symptoms early in their life, and they've had this whole distrust and stuff
Angry.
lots of health professionals. They're very angry. And that then leads to the mental health stuff. And that's why then a lot of people then write it off as being mental health or psychosomatic, or, it's like, no, it's not. It's like they're actually true symptoms and things, but they can vary from person to person and things. So, so that's hence why, doing a lot of that screening, and we can do it as continence nurses because we're asking lots of those kind of intimate questions and stuff anyway. And then you've got also when you're kind of getting into the 50s and stuff, and you've got the, living the dream, the perimenopausal and menopausal women, and things that can also, overlay, have different overlay and stuff as well, but where you can get different body inflammation and things. So it's just this space that it blows my mind all the time. And I come away from those conferences going, oh my God, like this is something that's not well recognized. And so if we can get the word out there and get people knowing what you need to be out there looking for, then it may help sort of people in their pathways to earlier diagnosis and recognition and management, and better outcomes for people. And so hence why I've sort of become quite passionate in this area. And a lot of the nurse continence specialists in private practice are used to me rabbiting on about it, and things about how important it is. And I'm always saying them, go and do this, these EDS Echo series, the education series, because it's brilliant. Like, it's one of the best Echo series and stuff. And I know the Rare Diseases Network also do like an Echo series. They've got some really interesting stuff, and you'll come across clients yourself that you go, oh my God, that's what they had and I missed it, because I didn't understand it, and things. And so maybe, for some people who have the mast cell stuff, they might need to take like an antihistamine every day, and things like that. So there's different medications that, you can use to kind of dampen down symptoms, and things, while you're kind of identifying what those triggers are potentially, for certain triggers that may, so
I have two questions for you.
Yeah,
the first question is, all those types of Ehlers-Danlos syndrome,
yeah.
I mean, apart from being linked as, they're so disparate. I mean, they're so different. You've got your autonomic, cardiac, all that. What is it that links them all? That's the first question.
Joint hypermobility.
Sorry?
So joint hypermobility is the one thing that pretty much standardized usually across all of the Ehlers-Danlos, but you'll see like in some of those later Ehlers-Danloses that, they're so rare that so you very rarely see them, and that's why you almost see like the hypermobile EDS. So, people with hypermobile Ehlers-Danlos syndrome with that joint hypermobility being significant, and like the classic EDS, which has more of the, the elastic skin and the bruising and that kind of stuff that goes with it. But the vascular EDS, when you've got lots of, kind of really awful bruising and, and they may have had, for some people as they're getting older, they might have had strokes, and they may have had, other cardiac dissection stuff and things like that. You're like, because of the elasticity of their vascular system, that's the one that's more catastrophic. They're the kind of things you're sitting on an aneurysm, and you may want to do some further testing around that to know if you actually got that as an issue or not. Yeah, some interesting. So they do genetic testing. If there's signs there that there's some vascular EDS, they'll get you straight off to the geneticist, and you'll be a priority and stuff to be seen, and cardiology and things like that. You'll see cardiology. But, you can go along to different health professionals. Gastroenterologists don't really necessarily recognize, a lot of even the mast cell activation stuff. They don't kind of not great believers in it. And I'm listening to Rebecca Ryan is one of the gastroenterologists that's based up in the Gold Coast. And she's fascinating to listen to. She's brilliant. She presents at all the different, echo series and the conferences. And she's a gastroenterologist that is brilliant. Like she just made so much sense and things. And I learned a lot from her and Megan Thomas as well. So the GP and stuff.
That was my second question to you, was who are the peak people that
Yeah.
that are that are in this area. I mean, who?
Certainly, Louise Toffs is the pediatrician that is based. So I used to work with Louise at the Children's Hospital at Westmead. She used to head up our connective tissue disorder clinic. And so Louise now has left Kids Hospital, is now just working privately at Narrabeen in New South Wales. So she is the pediatrician based in New South Wales that sees most of the kids. But there's very few, like when I've gone to inquire for like Melbourne and stuff like that, it's like, how do we get in people to see genetics through Monash or and they're like, it's really hard to actually find the people that actually have an interest and understanding in this area. And so often defaulting back to the Ehlers-Danlos Directory of Health Professionals. A lot of people are listed there. So there's therapists and things from Active Health Clinic or something based in Melbourne who are really excellent at doing all this kind of joint hypermobility stuff. Like there's people like that are listed. They were presenting as well at the conferences and stuff, and they were excellent. Yeah, I say if you've got an opportunity, if the Ehlers-Danlos conference comes out to Australia again, I would highly recommend going. It was one of the best conferences I've ever been to. It was fascinating and it blew my mind. And hence why I'm certainly not an expert in this area because I'm still learning myself, but I just wanted to share the information that I've
Yeah,
learned so far and what I'm doing about that. So,
it's just, yeah.
yeah,
Thank you so much.
that's all right.
Thank
Thanks.
You're very
We've
welcome.
got three. I've got Colin, Cass, who I will allow to speak in a minute. But first of all, Sarah Dirksen said that she did an assignment or an assessment, on a 34-year-old with all of what you listed over a period of 2 decades. Beautiful lady, completely traumatized by her journey as a child. And then Donna's asking, with the patient that had constipation and ongoing bowel issues, do you find that the colostomy is the answer? Because she's saying that she's got a client who still has slow transit constipation even after colostomy was formed.
Yeah, no, I can, yeah, literally, yeah, in the sense that for this client, I believe it worked okay for her because I think her biggest issue for where her issue was, I think what was happening is that between the sigmoid and the anus, because of the elastic fascia, I think it was actually kinking. I think she was actually kinking at that point, and that's why nothing was coming out and things. So for her, just hitting that a bit higher, um, avoided that. So for in that particular case, that kind of worked okay for her, and things. I believe I haven't actually seen her since she went off and saw the colorectal surgeon, and they kind of then managed it for NAB. But I haven't actually seen her again, and that was a few years ago now, and things. So yeah, but certainly. Yeah, super challenging. Like that I didn't really understand like why when people sat on the toilet beyond kind of them not being able to relax their pelvic floor muscles, I was like, why is 300 mils of fluid not coming out? Like that really, really fascinated. So yeah.
Okay.
And so yeah, anyway.
The last question we've got is from Cass. You can take the floor now. Unmute yourself, Colin.
I think he said he's just frozen or something. I think his screen's just frozen, he said.
Oh, fair enough. Okay, well, whilst we're waiting for his screen to unfreeze, and hopefully it will happen, there's just absolutely fantastic feedback in the chat about the presentation. Everyone just loved it, and was just so grateful that you're able to give us some knowledge because the majority of us don't have much of a clue about this condition. As you said, it baffles a lot of the doctors by the sounds of it.
And it baffles lots of health professionals. With the people that actually kind of go and do this deep dive and get invested in this area, you learn so much from them. And so, I said, like I follow a lot of people now, like on TikTok and things like that, because they talk about the lived experience. There's a particular girl called, I think it's Life with Layers is her handle on TikTok. And she talks about the intersect between, the mast cell activation and POTS and hypermobile EDS and things. And she's fascinating to listen to the lived experience. And that's how I actually learn. I know ideally that you're kind of like, you don't learn off TikTok, but you do. You listen to how people have been medically gaslit, and then you try to not do that yourself. You know what I mean? If it's one thing that I do is like you listen to the people, you put the questions and the screening tools around that. So the screening tools that I showed you, you know, they're mainly for adults and things, but I certainly have said to families, I want you to go and fill that out, what you can. Obviously for the children, you don't tick the alcohol bits, but you know, like and different things. But that might give you some information to be able to give to a doctor and say, I think we need to investigate this further. Things. So I think we have a really important role as nurse continence specialists and continence nurses across the board of putting some questions around this and questioning our medical colleagues and things as well. I think it's important to challenge them and challenge the way that we think about it. So
fantastic. Thank you so much. And Colin's asking for the Echo link to be put in the chat when you get a minute, Jodie.
Oh yeah, yeah. So if I've actually put it on the Ehlers-Danlos Society is in my presentation, which I will send through, and stuff. It's if you just write Ehlers-Danlos Society, that will go to Ehlers, and you go into health professionals, and it shows you the Echo series, and you can link to it from there. There's different Echo series for around the world. I did the Australasian one, and said there's one coming up in September. And things, but yeah, you can literally just write Ehlers-Danlos Echo, and that will also come up and things, but it's all part of the Ehlers-Danlos Society. They've got a brilliant webpage, a brilliant organization that's really, you know, raising the profile of this condition and its associated conditions and things. And I think it's, yeah, they've got some really great resources. I would highly suggest you go and have a look on that website.
Thank you so much. We'll have to wrap up now, but I'm so grateful, and we're also grateful for you presenting to us. I'll just give some, I'd like to thank the Education Subcommittee for organising for you to speak tonight, and the Education Subcommittee will, you can look forward to some great webinars that they're working on between now and the end of the year. The Executive Committee is working very hard, but there's only a few of us on the Executive Committee because unfortunately we lost our secretary due to personal reasons. So if anyone would like to become secretary of CONSA, just reach out to one of the Executive Committee and we will happily take your nomination for secretary. That's all I had to say tonight. Our president is very unwell, so unfortunately she won't be able to say anything tonight, but we look forward to keeping you in the loop about more education in the future, and there is talk in the background that hopefully next year we can run another actual face-to-face study day, and we'll, as I said, we'll keep you in the loop with that, and we're working on that in the background. So I'd like to say good night to everyone, and I hope you have a good night, and look forward to seeing you in the future when we've got more education to provide. Good night, everyone.
Thank you.
Thank you. Bye.